Okay, we're good. Recording is on. All right. Hello, everybody. We are covering chapter 8. This is not a long chapter at all, y'all. Um, we're looking at our hormones. Now, chapter 9 is our mini session. It is up on Moodle. So make sure if you hadn't had opportunity to go check it out, I am going to sprinkle, or I have sprinkled a couple little questions. And I'm going to break down some concepts that have been a little bit more confusing with chapter 9 towards the end of this live session, but this still is not a very long live session. We do have a fast round of Kahoots, and then we're going to wrap it up. But before we get started, we have our quote of the week. So with 4 weeks left, I can't even believe that. I'm like, 4 weeks left. I thought this quote was really awesome. There are no limits to what you can accomplish except the limits that you put on your thinking. Now, as future STs, this quote is just a reminder that the biggest barrier that we face, it's not going to be the complexity of the instruments. I know, bear with me. I know you're probably like, are you kidding me right now? No, it's not. It's not going to be the long hours of studying or even the pressure of getting ready to get into the operating room. It's actually doubt. If you believe you can learn, if you believe you can adapt and grow, you will. Every challenge that you meet in the class, the lab that's coming up, clinicals, it's actually shaping you into someone capable of supporting life-saving surgeries. Do not let fear or negative thinking shrink your potential. You are stepping into a profession that demands focus, skills, and heart. And you already have what it takes to rise to the challenge. So I'm letting you know, believe in yourself. All right. Now, for our mini session, I had some questions. So what I wanted to do is to kind of grab couple. We have 2 questions now. We have 2 questions towards the end. Okay. Now, which statement best differentiates the interoperative use of hemostatic agents from systemic coagulation? Is it A, hemostatic agents are applied locally at the surgical site to enhance clot formation and control bleeding, while systemic coagulation circulates throughout the body to promote overall clotting? Or is it B, systemic coagulants are administered to prevent intraoperative thrombosis, whereas hemostatic agents are given intravenously to dissolve clots at the surgical site? The answer is A. Now, we're going to kind of go over, and this is one of the questions that I'm going to kind of touch on towards the end. So it is A, because it describes local versus systemic action. Now, B, for those who kind of put B, sounds medically plausible, but it's kind of where, if you hadn't been to clinicals yet, right, which we haven't, it's hard to kind of critically think to get that. But this is why we're here. Now, systemic coagulants are not for like dissolving clots, and hemostatic agents are not given IV to lysis or kill clots. Okay, so we're going to break that down. Okay, so you can see why I grabbed that question. Here's the next one. Warfarin sodium or Coumadin is primarily used for short-term management of thrombotic conditions and works by inhibiting vitamin K activity in the liver. True or false? True or false? And it is false. Now, Coumadin is primarily used for like long-term management for conditions like DVTs or deep vein thrombosis, pulmonary embolisms, and stroke prevention. So it's not going to be something short-term. It's going to be something that these patients, unfortunately, are going to have to manage over time. It works by kind of going in and slowing down or inhibiting the vitamin K activity in the liver, and that prevents the synthesis of the clotting factors, which helps to prevent blood clots. So therefore, the statement is incorrect. All right, now we have two more later, but we're focusing on hormones, which means we have to look at abbreviations related to hormones. We're going to talk about the endocrine system. We are going to look at the function and the importance of the pituitary, the thyroid, the parathyroid glands, as well as the adrenal glands. And I've kind of separated them so you'll know exactly where they are. Imagery wise, because I really feel like that's important and really see how it all comes together. We're going to also explain why epinephrine is of particular interest for us and identify safety practices regarding the use of epinephrine, especially in the field. And we're going to identify two major groups of adrenal cortex hormones and purposes of each. Okay, so hold on. It's going from blurry to clear, but it's getting better. Is everyone's screen blurry or is it getting better? No, okay. Okay. Because I see some that are saying that there may be blurry. Not anymore. Okay, perfect. Okay. If for some reason my images are trying to come in, just let me know because I was trying to get images that are kind of cool, but technology may not be up to letting us be great. Okay. Now we start off with hormones, right? And why it's important for us to understand that. So first we have to talk about what are they? These are chemicals made by glands and they're carried in the blood. They control important body functions like growth, metabolism, and of course, reproduction. Now, in surgery, they're sometimes given during to kind of like they're given um, to control bleeding, oxytocin. Okay, that's one we use. Epinephrine is also given to reduce bleeding and helps local anesthesia last longer. We look at the purpose though. Homeostasis, keeping the body stable during surgery. Now, because we also have theory two, I want to make sure we differentiate hemostasis versus homeostasis. And you're probably like, well, this gets confused, especially since we have pharmacology and theory two together. So in the past, many students do confuse the two terms. Hemostasis refers to the process of stopping bleeding, clotting, or vasoconstriction. Homeostasis refers to the overall physiological balance. Now, both are extremely important to us. Hemostasis during the operation, homeostasis during recovery. Okay. Now, we also look at stress response. Surgical trauma triggers hormonal changes. We have to understand this because it helps us anticipate certain complications. Remember, we have to sometimes think 3 times further during the case. Like we have to be 1 or 2 steps ahead, and a lot of times, at least in our mind. We also look at temperature regulation. Patients under anesthesia are prone to hypothermia. So that means maintaining homeostatic temperature is going to be important for clotting, wound healing, and reducing infection risk. And then there's that acid-base balance. Anesthetics, ventilation, and blood loss can really disrupt the patient's natural pH. Now, knowledge of homeostatic mechanisms helps us and our team kind of correct metabolic or respiratory acidosis, which is one thing we do not want to happen in the operating room. But hormones also have functional support. They control bleeding, they support organ function, and they aid in recovery. So for us, we need to know when and why hormones are being used. That's why we have this course. We have to be able to safely prepare, handle, and pass our hormones to our surgeon, if need be, and communicate clearly with our team about medication use. But remember, we're always going to trust and verify. We're not going to just be like, oh, yes, come on, circulator, put that on my field. I'm going to go ahead and give it to my surgeon. No, remember, we're always going to verify, repeat, and repeat again. because again, we are the patient's advocate. We Hormones also regulate growth, energy use, reproduction, and other vital processes. So understanding the effects just helps us anticipate our surgeon and our patient's needs. Okay, so the image is going to be a little blurry, should be coming in, okay? Now, the endocrine system is a communication network in the body that works with the nervous system to maintain balance. That's that homeostasis. It sends out chemical messages called hormones through the bloodstream to specific target cells located throughout the body. Now, the endocrine system regulates our blood sugar, our fluid levels, and our stress response. Hormones may be given during surgery just to keep the patient stable. Again, epinephrine, hint, hint, for bleeding. So we get our response to stress and trauma. Surgery is going to be controlled trauma. We are taking some type of cutting device and a lot of times cutting into a patient. That is controlled trauma. Now, the endocrine system helps the body really manage stress during those procedures. So there's common disorders. You have too little hormone, hyposecretion, or too much hyper. And either one can complicate our surgical procedures. Example, thyroid issues may affect anesthesia. So the anesthesia provider is going to really be monitoring and letting us know. There are types of hormones. Let's say from cholesterol. You have cortisol, reduces stress and inflammation. We have aldosterone, controls electrolyte fluids. Estrogen, progesterone, these are reproductive. We have androgens or testosterone, which are the male traits and muscle growth. But there's also non-steroid hormones from amino acids. Epi and norepinephrine, that fight or flight. These are used in surgical surgeries. We have thyroxine. This controls metabolism and energy. The thing to really know is that when we talk about hormones in surgery, we're controlling bleeding, we're reducing inflammation, and we're managing stress. So that means we're going to be trusting, verifying, passing properly from the sterile field using aseptic technique. And we look for endocrine imbalances that affect surgery and recovery. So we have the pituitary gland, often called the master gland. It plays a key role in controlling other glands in the body. It is so important for regulating reproduction growth and other vital processes. I talked about Pitocin a little bit. Now, when we look at Pitocin, it simulates uterine contractions during labor. In C-sections, it helps stops postpartum bleeding. Let's say if the uterus doesn't contract strong enough, so they'll give the Pitocin to kind of get the contractions going. Now, this is important, okay? And I'm noticing that my slides are just kind of blurry. Pitocin, you do not want to get it confused with Pitressin. Pitocin is oxytocin for uterine contraction obstetrics. Pitressin, make sure you guys are writing this down, is a vasopressor, okay? It regulates water balance used for condition like diabetes or diabetes insipidus. Do not get those two confused. You do not want to give vasopressin when the surgeon needs Pitocin. Okay? Again, we're trusting, we're verifying, we're a team in there. Now, we're double checking labels, we're communicating clearly, and we're trying to avoid dangerous mix-ups. That means that we need to know when and why oxytocin is being used in obstetric surgeries. We also have to be aware of Pitressin effects if using during surgical procedures. Here's a quick question you guys can type in. Again, if you don't know it, that's okay. Why do you think confusing Pitocin and Pitressin could have such dangerous consequences during surgery? I feel like I need to replay my. What do you guys think? Well, I want you to think of reproductive versus water balance, right? they're working on two completely different systems. Giving the wrong one could fail to stop bleeding, which would be horrible, right? Or disrupt like the fluid balance, which are both life-threatening in surgery. Yep. Okay, I think my images are starting to look a little bit better. Now, we look at our thyroid gland, right? The largest endocrine gland located in the neck. It's made of two lobes connected. It regulates metabolism, energy levels, and calcium balance. But why is it considered the master gland, you ask? Great question. The hormones that are produced are T4, which is thyroxine, and T3, which is triiodylthyronine, and they control metabolism and energy. It also has calcitonin, which helps regulate calcium in the blood. Now, preoperatively, thyroid hormones, doesn't matter if they're natural or synthetic, they do treat hypothyroidisms. So patients should be within normal thyroid function before surgery. Imbalances affect anesthesia, wound healing, and stability. So this is why we kind of recognize thyroid disorders, because they can affect how the patient undergoes anesthetics and ultimately how they come out on the other side of surgery. What we do is we support safe surgery by just identifying the thyroid medications during the prep. We'll talk about it, time out. We'll talk about that in 300. And then we understand how pre-op thyroid health impacts our surgical outcomes. So we talk about the thyroid. Now we look at the parathyroid gland. And as you can see, why I broke it down so you can really see where these organs are. Small yellow-brown glands usually found behind the thyroid, okay? Sometimes hidden in fat tissue. Their main job is to control calcium balance in the body. Now, your parathyroid, your PTH, again, regulates calcium. Now, calcium is important for nerves, muscles, and again, blood clotting. So there are some disorders like hypoparathyroidism that may require a patient to be on some type of hormone replacement. Unstable calcium can cause muscle spasms, or let's say the wound just isn't going to heal properly. Calcium, again, for these type of patients has to be monitored after surgery, especially if the patient's having some type of thyroid surgery. If the glands are damaged, hormone replacements may also be needed. We have our adrenal glands. They're small, pyramid-shaped organs located on the top of each kidney. They play an important role in producing hormones that help the body respond to stress and maintain balance. So there's two parts. You have your medulla, which is the center. It produces the epinephrine and the adrenaline and non-epinephrine for that fight or flight. And we have our cortex, which is our outer layer. It produces cortisol and it regulates metabolism and our electrolytes. Now, the chapter talks about the dilute injection. So make sure you guys are reading on it. For epinephrine or adrenaline, we're talking about 1 to 100,000 or 1 to 200,000. This is going to prolong anesthesia. For topical, we look at 1 to 1,000. This is really important to make sure because you may have both strengths on your field, right? They're both clear liquids. So you're going to make sure things are labeled. Now, the topical controls bleeding in small vessels, the middle ear in surgery, like a middle ear surgery, we may have the topical. Now, it causes vasoconstriction, where the blood flow is reduced, which helps with less bleeding. In delicate surgeries like the ear, it is only applied topically, not injected. Normally, when I'm doing a tympanoplasty or a mastoid tympanoplasty, I have small little cottonoids and we cut them up. We have the injection, we dip them, and then we have them, I usually give it on an alligator and I hand that to on an instrument and hand it to the surgeon with a microscope, and they'll place it, and then we'll take it out. We're not injecting anything. It's just for topical use. Okay. Now, other hormones that we think at, we have norepinephrine and dopamine. These are stress response hormones. They're rarely used directly in surgery, but it's still important for us to kind of know about. So here are our takeaways. Epinephrine, adrenaline, know both names. You may see it either or, know both names. Dosage does matter. Different concentrations for different purposes. We look at delicate surgeries. This is vital for controlling bleeding and supporting anesthesia. And knowledge of just knowing these hormones makes it safer, more effective when we are in our surgical procedures. We have our adrenal cortex. This is the outer layer of the adrenal glands. Produces hormones critical for maintaining our balance in our body. These hormones fall into two main groups, okay? You have glucocorticoids. These hormones are surgically significant because they reduce inflammation. Examples would be where we're injecting into a knee procedure, or let's say we're doing a shoulder arthroscopy where we're taking a camera into the shoulder, or even cataract extractions where we're trying to minimize that post-surgical inflammation. And then we have mineral corticoids. These are less relevant in surgery. Still need to know about them. These hormones regulate our electrolyte and our fluid balance. Now, when we look at steroids in surgery, steroids can be given orally, topically, intramuscularly, or rarely intravenously. It's all going to depend on the medication, the steroid itself. It may be long acting or short acting. When we talk about palliative care, we are looking at conditions like arthritis. Steroids do relieve symptoms of pain and inflammation, but they do not cure the condition. And this is why it's called palliative care, because we're kind of just trying to maintain some type of normalcy for this individual. We have our pancreas. Now, the pancreas is the gland behind our stomach, and it has a unique role in both digestion and hormonal regulation. Now, anatomically, it's divided into three parts. You have the head, the body, and the tail. Okay. Again, dual function, produces digestive enzymes. And for endocrine, it releases hormones into our bloodstream. Now, our hormone produced by the pancreas is none other than insulin. It lowers blood glucose by helping our cells kind of absorb that sugar that comes from the blood. And then glucagon. This raises blood glucose by kind of signaling the liver to release stored sugar. Now, these hormones work together to regulate glucose metabolism, and this is providing the body with the vital energy source. But why does this matter to us? Now, insulin and glucagon are very important for managing diabetes mellitus. They have no direct surgical use, but it's still important for us to really recognize how diabetes affects surgical patients, wound healing, infection, and anesthesia complications. We get in the ovaries. These are paired glands located in the pelvis cavity. They play a critical role in producing estrogen, progesterone, hormones for female reproductive health. When we look at the hormones itself, right? Sexual development, regulation of your menstrual cycle, and maintaining reproductive health. Progesterone works with estrogen to regulate the menstrual cycle and support pregnancy. But we use it sometimes for HRT, which is hormone replacement therapy, which is used to relieve symptoms of menopause. There's also palliative use. Estrogen can be used for certain cancers, such as breast cancer, prostate cancer, in cases where the cancer is sensitive to estrogen. So they're not going to just give it to everybody, but once they've done their testing and determine what type of cancer they have, And if the estrogen or the progesterone estrogen works, they will give it. Also, for patients having vaginal hysterectomies, we'll sometimes apply topically estrogen on our vaginal packing or even after a vaginal hysterectomy because it is going to help promote healing. But there's other conditions. Birth control hormones, which include estrogen, may be used to manage endometriosis or even fibrocystic breast changes. Now, estrogen's role in hormone replacement and cancer treatment is important, but its direct surgical use again is limited. Post-operatively, it's going to be more for like our vaginal hysterectomy patients when we do the cream with the packing. So just keep that in mind. And then we have the testes. They're paired glands located in the scrotum, and they're responsible for producing testosterone, the primary male hormone. Now, testosterone is an androgen hormone produced by the testes. It again plays a crucial role in male sexual development, reproduction, and maintaining muscle and bone strength. It also is used as replacement therapy. Testosterone is used for men with low testosterone levels, but did you know that it can also be given for breast cancer? Yes, it can. It may be given for certain types of advanced breast cancer in females. So you may see a question like that somewhere. But there's other treatments. It too can be given for endometriosis and fibrocystic breast disease. Now, the name of the drug is danazol, and it's used to kind of treat those conditions in females. There's also ablation preparation. Women may be placed on that danazol therapy before surgery just to reduce the thickness of the endometrial layer. For us, understanding testosterone itself is not necessarily, again, a direct surgical use. It's sometimes used to treat specific conditions. Again, endometriosis, fibrocystic breast disease, and perioperative preparation for endometrial ablation. Not a long chapter. Why am I saying that? We're getting ready to ring the bell again. True or false? Intraoperative use of parental anticoagulants. I don't know why the screen is doing that. Just go with me. True or false? Intraoperative use of parental anticoagulants is intended to inhibit clot propagation, whereas fibrolytic agents are required to actively lyse established thrombi. True or false? What do you guys think? The answer is true. It said false, but it's true. All right. We're going to pretend like you guys can't see the screen. The next one is a matching, but I'm going to send that to you guys. I have it. I'm not sure why my computer is doing this. I love technology. With that, like I said, it's not a long chapter, but before we get into our Kahoot, what questions do you have for me besides why is the computer screen doing that? It's not one I can't do anything about right now. Okay, so with that, let me look at the Kahoot. Maybe it's my computer today. Let me see if I can refresh. It's the same. Okay. This may be a little bit tricky today. We'll see. 509031. 509031. I'm gonna go from my computer, my phone too, to see if maybe on my phone it won't be as crazy when I log in. Again, if you are not able to join, do not stress. Cool. So hopefully you'll be able to see the questions. And I will provide this actual PowerPoint for y'all. It'll be in the live archive section just so you can actually see the images a little bit better. But thank you guys for kind of just going with the flow, but you will get this particular presentation so that you can actually kind of add your notes to it. and actually kind of see exactly where the images are that we were speaking at. All right, let's go ahead and start. Which hormone does the pancreas release to lower blood glucose levels? Blood glucose levels. It is insulin. Insulin. So, caveat. This is one of those where 5 seconds for the true and false, 10 seconds for the multiple choice, because we're trying to fire up those synapses. Okay, you guys? So this is where we're not going to second guess. We're going to go in, pick, and be ready. Here we go. True or false? 5 seconds. Testosterone is used in females to treat endometriosis and fibrocystic breast disease. You know it. You know it. Just click. Yes, that is correct. It is true. Remember, testosterone and the female, I'm not going to say the name because we may have that question, both can be used as palliative care to treat. Next question. Estrogen can be used as palliative therapy for advanced prostate cancer. True or false? True or false? True. I almost gave it away with the last one. It is true. Remember, both testosterone and estrogen can be given as palliative. Which of the following hormones is secreted by the thyroid gland? Calcitite. I can't even say it right today. Yes, blue. Next question. Which of the following is not a function of hormones in the body? Not a function of hormones in the body. I can't even I believe I wrote that as an answer. Directly performing surgery. Hormones are not doing that. Next question. True or false? Glucocorticoids are primarily used for reducing inflammation during surgery like shoulder arthroscopy. It is true. You guys are on it. The pancreas functions as both an exocrine and endocrine gland. Exocrine and endocrine. It is true. Remember, it works for the digestive as well as for hormones. So in both has two hats. Two hats. Number 8. What hormone does the adrenal medulla primarily produce? Norepinephrine. Good job. Okay. True or false? The pituitary gland produces hormones such as oxytocin, which stimulates uterine contractions during labor. True or false? It is true. And our very last question. What is the primary hormone produced by the ovaries? Primary hormone produced by the ovaries. It is estrogen. Good job. Good job. Good job. Now, I know this was super fast and we kind of went through, but this is another method, another kind of tool to put in your toolbox to kind of help with second guessing. Because one of the things that I tend to do when I'm taking big tests or any test is I will second guess. But doing these little exercises and even just changing, like building that up where you're like, that you answer it, you go, and you look back and you're like, I did that. So, good job, everyone. Good job. All right. Still trying to figure out what's going on. So happens when you try to get all fancy. Now, our quote of the week, there are no limits to what you can accomplish except the limits you place on your thinking. And we're not doing that anymore, right? So we looked a lot at hormones, and we even kind of had a couple mini session questions thrown in the mix. For those of you that are watching the playback, how might using the wrong concentration of epinephrine during surgery affect patient safety? Why is controlling bleeding with epinephrine especially important in delicate surgeries like those involving the ear? And what would happen if we, as certified surgical techs, confuse the different names or forms of epinephrine? Now, I know this was a quicker chapter, so what you'll notice is our chapters are not going to be as long. So it's more opportunities if you have questions, whether it's from the exercises, from the knowledge checks, from the quiz. Send me those questions. That way we can kind of break them down in the live sessions. Okay. What questions do y'all have for me? I know I asked earlier, but if something has come up, I'm kind of looking.
Okay, since you mentioned it, Dr. Rulak, Professor Rulak, the exam, the mid exam, can we view those questions?
I will check. In the past, we weren't doing the actual questions. Let me verify, and then I kind of will send out announcements. I'll send you a message and I'll send out an announcement as we move forward um with kind of like the expectations, so we'll all kind of know. So let me make a note now so I don't forget in my age. Okay, so I have that, and then I will get that back to you probably this evening, as soon as I can find out. And I saw your question. I was going to get back, kind of go back, and then I was getting tied up. But yes, I will make sure I get that. Hopefully this evening I'll have an answer. So, we'll kind of know, especially moving forward, getting ready for our final exam. Great question. Any other questions? Not going to keep y'all. Um, with that, you guys, thank you everyone for being here. I want you guys to have a wonderful evening. Tomorrow we have a lot of videos in theory because we start talking about passing instruments and actually gowning and gloving. So I look forward to seeing everyone who can attend tomorrow's live session. Good night, everybody.